a Japanese study, and this is sort of an indirect assessment, sports and pediatric chronic pain. They actually looked at artificial turf versus natural turf. You know, where would you have more injuries and how was that? But they also saw this with 300 soccer players. But they saw that increased incidence of chronic pain in the artificial turf when you had younger age and prolonged training. And that's one of the concerns. We see a lot of kids start to play sports, and they become very specialized at a very early age now. You have your pitchers, and I have a 14-year-old, and he told me, I don't know, he was 10, he said, I'm too old to play lacrosse, I can't join them, I mean, that's done. These people they're too good. So, you know, they feel themselves that by that time, you know, the train is out of the station. Then an American study in some female club gymnasts. So these are higher level gymnasts. This is not your local rec center. These are further up. 96 was a high rate of overuse injury, career incidence of concussions, and stress fractures. And this is certainly the population that we see in a pain clinic then. Yeah, this is the career incidence during the life of that while they are gymnasts. 30% concussions, 17% stress fractures. These are lower extremity fractures and back vertebra fractures. Obesity, and developing problem. We talked about it a little bit at lunch, how obesity, inflammatory mediators within fat cells, and how obesity is related to chronic pain. And in this pretty recent study, you can see that there was a higher percentage of obesity with certain pain complaints. This is Oregon State. These were people with back pain, high incidence of obesity in this population. So a higher rate of overweight and obesity than in the normative sample. And then the BMI percentile was predictive of concurrent limitations in vigorous activity. So you have this, it's like a circle then. You can't participate in activities, you don't lose the weight, and you have more pain. Oops. Uh-oh, I hope I can go back. Up. Okay, so this population that we saw, was that really the one before? Yes, that was the obesity, good. So this is what we had. This is not totally completed, so there's some preliminary data there. Multidisciplinary pediatric pain clinic in Baltimore, and this is sort of the very characteristic population of what you would see in a pain clinic, children's pain clinic in the United States. The average age is, they're usually teenagers. You will see some younger ones. The youngest one I've seen is a 2-year-old, and most of them are females, and most of them are Caucasian. We are a little bit different because we see a higher percentage of musculoskeletal pain, upper and lower extremity pain, abdominal, and then some generalized pain. I'm not a headache specialist, so I don't see a lot of headaches. There are other people. We have a concussion clinic, and they usually go to the concussion clinic if that's the etiology. Average intensity of pain is pretty high, and that's the average high range of their pain. What we were interested here is the stressors that contribute to pain: school absenteeism, sleep disturbance, family conflicts, social withdrawal, mental health concerns, and on average this population had 2 to 3 of these additional stressors. There was a positive correlation between stresses and the lowest reported pain, but not with the others. We also saw there were more stresses in patients with abdominal pain and generalized pain than in the other groups. So these are kids who are, it's not inflammatory bowel disease, this is what's called functional abdominal pain. This is sort of their irritable bowel disease. You know, they had a workup and it's all normal, essentially. But they can have significant pain and come to us then. But there are more stressors that can be identified in that population. management of, this here is a study from, this is George Chalkiadis from Royal Children's in Melbourne, and I picked this here, very similar, it's 277 patients, and they looked at what population they have. You can see it's almost the same as ours. But I picked this here because he listed here the number of school days missed, and you see that some of these children missed 21 to 40 days, 40 to 60, over 60 days. So a child who misses more than 40 days will not pass that year. So they get home and hospital teaching, which leads then to a withdrawal from their social environment. All right. Psychiatric disorders, there are, so 21% of the kids in this study, and it's probably the same in other studies as well, and centers, have relevant psychiatric disorders. And as Jennifer Hathensworth said earlier, this is not necessarily your diagnosed major depression, but these can be anxiety, affective disorders, or disruptive disorders. And headache is independently associated with one of these psychiatric disorders. So a mental health assessment in a pediatric chronic pain population can be very helpful. Family history, and this is interesting because this is very pediatric, and we have talked about that on the adult side. So when you deal with a pain patient, you don't just have the patient, you have the whole family. And that has been explored and investigated more in pediatric population. So these were children who had rheumatic disease, so juvenile rheumatoid arthritis, and so they have clearly a medical diagnosed disease, they have inflammatory processes, and they rate their pain. But what was interesting is the parents in the rheumatology clinic, the parents had on average 3.5 chronic pain conditions, chronic headaches, leg pain, back pain. 90% had at least one chronic pain condition. Higher pain levels in the child were associated with a current or mean level of pain in the parent, higher levels of disability, and a more parental use of healthcare for pain. So there's some patterning, some is probably genetic, so all that comes into play. I don't think I have the slide on catastrophizing, but a parent who could, yes?
How much of that could simply be the recognition and acceptance of pain?
It can be. We know, though, that parents, so you can do catastrophizing in parents as well. There are scores for children, scales, and for parents, and you can see that if you have a parent who is a high catastrophizer, that child will have a higher pain score. So there are interactions between members of the family. There are enablers as well, or helplessness. That's actually very common in parents. They just don't, they feel helpless, don't know what to do for their child, and that increases anxiety in the child. So it's not always just, it can be recognition, it can also be a genetic predisposition.